So what I want you to do is spend the next like 5 minutes, 4 or 5, not a long time, thinking about your research question and putting it down on paper. Go. And if anybody doesn't have paper, let me know. We're writing our research question.
Did everyone badge in? I'm sorry to the creative thinking. If you didn't badge on the way in, please badge on the way out. And when you get the evaluation from Brian Wallace, please fill it out. Really, really helpful for us. Sorry if I interrupted the train of thought. I need to use myself some logistics.
That's Mike.
Yeah, I'm logistics. That's all for
Anybody need more time? Are we good? Okay. All right. So, what is a research question? I sort of poked around on the internet to see kind of what's out there in terms of developing your research question. There's a pretty good little resource that comes from George Mason, actually, which random, but they do a nice little blurb on sort of developing your research question. So this comes from that. But they define a research question as a clear, focused, concise, complex, and arguable question around which you center your research. And I think one important piece to note, a really important piece to note, is that as you're thinking about your research question, it's important that you ask a question about an issue that you are really curious or personally passionate about. So there's a lot of interesting research topics out there. There's a lot of funding opportunities out there. And sometimes I think we get confused or sidetracked or distracted by the fact that this is a really hot area that people are interested in. And even sometimes people encourage you to develop your research in a particular area. That's very exciting and hot to a lot of people, but not maybe you. And so at the end of the day, you're going to spend at least, if it's a paper, some significant number of hours on it. And if it's a research project or a research career, even longer on it. And no matter what that thing is, any hours that you spend will be torture if it's not something that you care about. So I think as you're thinking about your research question broadly, you want to keep in mind and do sort of a gut check on, is this something that I really care about? So why is a good research question essential to the research project process? Anyway, there's no right answer. There's no rest of this slide. This is it. Why does developing a research question matter?
Because then you can get some results. Because if you don't have a question, then you don't know what you're researching.
Right. So it helps you to figure out what you're doing. How many people in here have written a systematic review? Or some kind of a review? Okay. What happens, anybody who's had this experience, if you don't go in with a focused question?
You can get distracted.
It's awful, right? It's like one of the worst experiences ever. Because all of a sudden you realize that you're searching literature, you don't really know what you're looking for, and you're pulling papers because they're on topic, but then you can't, and you're in a pile of papers before you know it, and you really don't have any way of sort of setting some aside, and it becomes quickly frustrating and overwhelming. So that, I think, is sort of a microcosm for why it is important to have a good research question. And we're going to talk a little bit about what it means to have a good research question. So, steps to developing a good research question. So we already sort of touched on the first one. Choose an interesting general topic. So there's a balance, right, between something you're personally passionate about and something other people are passionate about. So I said it's totally a prerequisite that you have to be passionate about it, but actually it's also very important that other people care about it too, because there could be something that you're super passionate about, but if other people don't care about it and other people don't really want to fund that, then you're not going to go very far. So there's that sort of Venn diagram, and you have to find that sweet spot where this is something that is important and people care about it, and you have to figure out who those people are, because there's interesting research questions. I mean, all of us know that something that's very interesting to one group is not so interesting to another group. So you got to know what the topic is, are there people who care about it, and who are those people that care about it. And then you start to do basic research, because the other thing, basic literature review, because the other thing is you want to do something that is new, or at least a twist on an old thing. So you have to know what's out there. So that's the other thing I think a lot of times people think of really interesting questions, but maybe there's a whole bunch of literature on that topic. And while you're really passionate about it, it's interesting, there's really a lot of work that's already been done on it, and people may or may not get very excited about yet another thing in that same domain. As a part of this, you want to ask around, engage mentors. One of the things that I think happens a lot when people, especially if you're just new in an area, is you think you know the right words to use, but sometimes you don't know the right words to use. And so, or sometimes there's different words used in different fields to mean the same thing. So ask mentors, and ask mentors from different disciplines about the topic, so you get a sense for, are you really looking at a comprehensive lit review? And when I say that, I don't necessarily mean one that you're going to write up, although I encourage that, but in terms of doing your background investigation, are you using the right terms so that you can find the literature that's out there on your particular topic? That happened to me. I was really interested in work using community health worker models. And anybody who's done anything in that field knows that the nomenclature is a big issue. And there are at least 55 to 60 terms to reference community health workers in some form or fashion, or community health worker-like people. So you could call them a lay navigator, you could call them a promotor, you could call them a peer coach, you can call them and that's just, so if you're not using all of those words, you may miss a whole bunch of information that's out there and already know. Did you have a question?
Well, I was going to say, one of the things that really helped me in doing that, and it may not help others, but I create an Excel spreadsheet, and so I have columns like methods, conclusion, like what was a research question. And then you can sort of apply conditional formatting and highlight things different colors, and you'll start to see patterns of what has been done, and where there are little, like this will sound crazy, but where there are little white trails or things that haven't been done that can kind of guide you to your question. And that's literally kind of how my dissertation came about, was like, people have done this in this sample, but using this method, they haven't done that in that sample using that method, or things like that. And so I think if you sort of plan it out, it actually helps you to, and then when you do your lit review, you just go back to your Excel table.
Yep. And in a systematic review, you do that in a very formal way. But I think coming up with some system to help you organize what's been done is pretty critical. And so I also want to make the comment, that's exactly what I want you guys to do. So you guys are all different levels, and everybody has different experience and different ways of approaching this issue. Some people, this is brand new. Some people have been working on research questions for some years. So jump in, and if you have tips or things that have worked for you, definitely feel free to share them. Any other comments about doing the background search that people have found helpful? Mm-hmm.
I remember Jessie when I was like first trying to figure out what my area would be, Jessie Merlin. She advised me to keep a little notebook, and you have so many questions during the course of a day, but then they just kind of float around, and so just start writing them down in a little notebook. And so that was very helpful for me because as coming from a clinician background, there's lots of questions that you come up with during the day, and if you just keep track of them, and then like you said, start refining them, asking people what's known about this, start looking it up. I thought that was a great idea. I have a little book of questions. That's how I finally
keep it near the shower, near your bed. All those places when you're not intentionally thinking about something and you think of something.
Right.
Because that's you've got a phone almost always. So there are note sections in phones that are really good. I send myself an email sometimes. If I think of something and I'm like, I'm going to forget this, but I really think this would be a fun thing to do, and I'll send myself an email if I don't have anything to write on. Other thoughts? Yeah.
I think the other thing to look at is recent national meetings and also NIH Reporter to see what's being funded. So articles are good, but that's already been kind of completed. What's active? Yeah,
definitely. Definitely. If you think you have something that's just never been done before, and then all of a sudden you find out there's a 500-person trial ongoing, that doesn't necessarily mean you can't do it too. And that's a point, that I think is important to make is, what happens if you're working on something and you find out somebody else is working on something in the same area. That happened to me with the systematic review that I was doing during fellowship. That as I was submitting it, one came out. I was like, you gotta be kidding me after all of that work. But the thing is, it had a slightly different twist, and just because two things get published at the same time, it's as long as you cite what else is out there, people know that happens. That happens. And there's some good pieces about that because, things can be confirmatory, or not, as the case may be. So it doesn't make it less important, but it is something to note. Another thing that can be helpful as you're sort of batting stuff around and you're reading and you think, oh my gosh, they just did this thing that I was totally interested in doing and here's the paper on it. But if you go to the end of the paper, they document what next needs to be done in that area, right? They go ahead and say, future research should do, and then, they might be doing that too, obviously, if they've stated it, but that doesn't mean that other people can't work on it. So that's another great place to find sort of where the science is going and what kinds of things you might be interested in doing. Any other comments? Okay. So continuing on the steps to develop a research question, the next part after you've kind of done that background looking is to start thinking about your hypothesis. And I think, sometimes, especially as we move out of the basic scientists are really good at the hypothesis piece. It's an automatic, we have to have it there. I feel like sometimes as we move into health services research, it gets a little looser, and people are a little more lax around thinking about the hypothesis and actually putting down what is the hypothesis. But it's a really important piece to consider, and it really is a requisite for having a good research question and a good trajectory. So these are some of the questions that you want to think about is where do you think this research is going to take you? So you guys are all at the sort of fellow or early faculty stage. So you want to make sure that the research question you're thinking about is not a one and done, right? It's not like an interesting little problem that you then figure out and then it's over. Because right now you want to think about things that have legs. You want to think about things that you can build on that will then give you sort of a foundation for a continued trajectory or career. So yes, you want the project to finish and have some result, but that can't be sort of the end of the story, right? So think about how does this particular research question fit into where you want to go? What kind of argument are you hoping to make and support? So I think this is a really interesting question and piece that deserves 5 minutes of discussion. I do work, as I said, in community and in health equity and chronic disease management. And so I am very passionate about that. And one of the things that I hear discussed and that I think is really interesting, I do have opinions on it, but I don't think there's a right or wrong answer, is this tension between scientific rigor and advocacy. And can you kind of, so if you're going in, you have a hypothesis, that means you believe something, but you also may sort of want a specific answer. And so I think recognizing where you stand on the science that you're doing and keeping a check on the balance between making sure that you're open. So what will it mean if your research disputes your original argument or hope, right? That you're open to sort of all sides of your research, you know? If you think a certain intervention is going to work, but you have to be open to the fact that that may be wrong. It may be wrong because the study was wrong, or it may be wrong because it doesn't work. But whatever the case may be, you have to sort of plan your argument, plan your study, and just be cognizant of the fact that it may not go in the direction that you want it to go in. So how many other people have sort of thought about or grappled with this idea between research, rigor, and advocacy? Yes. You.
Kaylee?
Kaylee. Talk about it. In what context?
What's that?
What'd you say?
I just said I thought about it.
Oh, have you had to, do you feel like you've sort of faced thinking about that personally?
Sure. I
You
mean,
want to expand?
it's just people come in with different priorities and different levels of training. So a researcher wanting to go into a community setting, wanting to do like an RCT, that's not going to work.
Mm-hmm.
But you have to find a way to do your science scientifically while also honoring the setting that you're in.
Great, yeah.
I guess that's as far as I've gotten.
Anybody else want to add? Yes.
I was here for my fellowship. I work with folks in the Duke Policy School. So Kate Wetton led a number of grants and did work in the Southeast U.S. focusing on trauma and health equity. Did work internationally focusing on orphans. So things that could be very, advocacy driven and kind of, and some of Kate's struggles, and it was really interesting to learn from that, was because she was such a strong advocate, some of the people in the policy school were very critical and I think she did a really good job of doing data-driven advocacy. I mean, using NIH-funded science to drive the advocacy, but it was interesting just observing, kind of under her mentorship, some of the tensions she faced in the policy school and some of the criticism she heard about, you're too much of an advocate, not enough of a scientist. When actually watching her do it, I thought she did a really nice job of being incredibly passionate about these issues, but making sure to do good science and using those data to, put a case forward.
But I think involving people from the community, like for example, what we do in Black Belt in terms of data, there is interventions and patient-centered outcomes research. So when you involve the stakeholders, you and you're still in research because you use your rigorous methods, but at the same time, you're already patient advocate or community advocate just because you talk to them and you involve and you hear to their opinions from the get-go.
Yep, exactly. And so there can be major benefits to that. But again, I just think it takes being cognizant. So I pulled an article for you guys on this. I looked around to just see if I could find something that kind of highlights the tension here in case it's something you haven't really thought about before. I don't know if I have enough, but pass them around, see how far it goes, and then I have the URL at the back of this if you want to just look it up online. And the one that I printed out somehow has slightly larger letters, but you guys are young, but this is like microscopic type. So anyway, see if you can see it. If not, you can look it up. But I just want to read one little part that I thought was fascinating. So this is from a group in the UK who published this paper on No, I think I stopped it. Anyway, I'll pass it around after I add it. A group in the UK who used this study that was on food insecurity and nutrition worldwide and developing sort of, trying to study the problem and come up with some of the solutions. Anyway, they used that as a sort of case to talk through some of the, what they perceive as merits to research-based advocacy. But it was spurred by something that was happening in the UK that I thought was really interesting. So in the third paragraph, it says, the tension around the role of researchers as advocates is illustrated by the UK government's plans to introduce an anti-advocacy clause into all grants, which specifies that taxpayer money cannot be used to, quote, support activity intended to influence or attempt to influence parliament, government, or political parties, or attempting to influence legislative or regulatory action. And obviously it was a very controversial clause. This was I think in 2015, 2016. So I'm not sure what happened with that. It was like under debate, and I don't know if they ended up passing it, but there was a lot of argument in the scientific community against doing that. But you could see, and I don't know what, I guess we could probably look this up. I don't know, does anybody know, does NIH have language around this?
Yes, we do.
What do they say?
We're
I've never looked it up.
So
Might not be calling
there are specific ones, and I think it's around specific issues like you're not allowed to advocate for gun
So
control.
gun control, I know they have a policy.
And then there's a sort of more general one that you're not allowed to use any NIH dollars for political purposes. So
Read that as you may. I know
so
that.
it's pretty confusing, but there are specific carve-outs where you're really not, because they're.
Well, the Corey had that thing, I assume they still do, where you can't talk about cost.
Right, because of death panels.
Yeah.
So it's pretty interesting. And I know, a couple of years ago, we were at one of the national meetings for our translational diabetes research centers that are NIH funded. And they were unofficially telling us not to use a lot of language around racial and ethnic health disparities in titles, because they felt like there may be pushback against that. It was a very unofficial, there was no, it wasn't an email, it wasn't written down, it was sort of a, we don't know where things are going right now, this is something to just be cognizant of. They're going back and looking at where NIH is allocating dollars. I haven't heard that lately, but
At the ARC program directors meeting for the T32 last year, under the new leadership, the new administration, they talked about language around all Americans. So it was interesting, and I think, so this is coming to them from the feds in terms of the program. So that language about, even if you're doing health equity research, how does this benefit all Americans? But I'm not certain that our peers on review panels necessarily, that might be instructed that way, but this is what's come down.
I don't think it hits the review. In fact, probably there'd be pushback on the review panels.
There was pushback in the room.
Pushback every time the topic comes up. But not from the people who are allocating the dollars.
Not from those folks. They are very clear. They want this language to be about how does this benefit. Yeah, that was a very clear message. And then the CDC was instructed by the feds. Kaylee, you remember this? The 7 words that they were not allowed to use. There was a huge uproar in terms of the 7 forbidden words. Things like equity. We just pull them up in Google in 5 seconds. The 7. Yeah, I mean, evidence based. God forbid that there's science. Evidence behind something that we do. Yeah.
Vulnerable.
Vulnerable.
Transgender. That was in the title.
Yeah.
Other comments, yeah?
So I have a sort of smaller, more local example. So a friend of mine works in the arts and medicine program at UAB, and one of their programs is teaching sewing to women who are on high-risk obstetrics. These are women who are on bed rest for months at a time in the hospital. So we were trying to come up with a way to keep the hospital funding this program. And so we're thinking about, can we do some sort of evaluation that will, where we can do something that's rigorous and meaningful, but also, we don't want to have, preterm birth or birth weight as our outcome, right? Because we probably can't affect that.
Right.
Can we affect, quality, health-related quality of life, stress, those sorts of things? So trying to think about, how do we, we knew who our audience was. We wanted to do something that
Set it up for a win.
meaningful, but we didn't want to set ourselves up to
And that's this whole question.
swing and miss. Yeah.
That's really back to this whole question is what will it mean if your findings are not in line with what you originally went in thinking. And again, I don't think there's a right or wrong here, but I think there are important things to think about as you're setting your research question and your research agenda up for yourself.
And being prepared for the unexpected, because you might publish something and not realize that you really pissed somebody off. So it's really interesting. Sometimes you're like, wow, I thought this was a nice, well-done study, and for some reason it hits somebody because it's counter to what they believe or are doing. And
so a great example of that is a colleague of mine who was up at Michigan, who also was doing a lot of work with community health workers, and they wanted to do a study. They were working with a health system, a health center, federally qualified community health center that had community health workers. And as I tell this in retrospect, it's easy to see how this conflict arose. But at the time, things were just kind of moving forward, and she couldn't see it sort of with that sort of benefit of retrospection. They had community health workers that were paid by the health system. A funding opportunity came out that wanted to look at peer support, but you couldn't pay the people who were peer supporters. So what they decided to do was to add a component of peer support outside of the system with volunteer peer advisors, and then sort of they had the community health workers who were paid. Well, they ended up finding, and so the whole thing was like they really believed in this idea, and they had the health system involved, and they were a partner, and they did it right from the beginning. But then towards the end, as sort of all that meeting around things had kind of fallen by the wayside, and they were under the gun to publish the paper, and she'd already moved to another institution, they submitted the paper. Well, the paper ended up showing that both were effective. But that's a problem if one of them's paid and one of them's not. For the paycheck for the one who's paid. And they went, so the community partner pulled out, made them take their name off the paper. They were furious. That was Trisha. It was a complete, side, just totally blindsided her. And I think, being, and that's just a note to keep your stakeholders involved all the way through. Even as because maybe pitching, I don't know how you would salvage that, but things like that definitely come up, especially if you're doing partner engaged or stakeholder engaged research.
And studies of sham surgery, so there's been these big, like New England, that then you might get an entire surgical society, so it shouldn't dissuade you from doing your science, but at least, I think being at the ready, it's part of it.
Yeah.
I think if you do it, man, it's like, well done, good job. You've done something meaningful. If you pay somebody angry, you've done something meaningful.
The other thing that these folks argue that I agree with is that, in some ways, if you are sort of doing this research advocacy, if you do really rigorous science, it allows you to be a stronger advocate or to support other advocates in a more strong way, because you can really refute those people who don't believe it with data. But again, you have to do it right, or they'll poke a hole in it and say, yeah, but you didn't do whatever. Any other thoughts about the hypothesis part? Yeah?
I think this speaks to, again, of in the outset, especially if you're working with partners, to basically get that agreement in place of, if we find this, are you going to be, we ran into that with a for-profit company we were working with, and then basically the scientists were all on board, but then it goes to the legal or the business side, and they're like, no, we can't do this.
We ran into that in this health system, where somebody found something that the health system didn't want to find, and when they wrote up the paper, they were not allowed to agree.
Just about 10 years ago, I downloaded the data set for teaching the purpose, but then I find the positive relationship between patient satisfaction and the mortality rate. So I want to write a paper with my colleagues, and the policymakers don't like it.
They won't like it, right?
Yeah, but I think about 2 years ago, I read a paper about this.
Yeah, see, I didn't. We could do that. Okay, great. So this was a good discussion. Does anybody else not have? I have one more copy of this. Anybody? Yeah.
I have a question. How do you respond as far as whenever you do have potentially, or even in those conversations about at least setting up ahead of time, if we find results contrary to maybe what some of the stakeholders or their advocacy or their goals or anything, as far as ways to maybe mediate that from the beginning, versus just saying okay, well, this isn't working because if we don't find what you want, then you're not going to be on board.
Yeah, I think it's really challenging. I'm a big believer in transparency because I think if you try as best as you can to be completely honest from the very beginning, that's helpful on the back end if it works out. I was bringing it up as something that could happen. And then thinking about, I'll engage you. We can think through from your perspective why this may not be what we found, why we may have found what we did not expect, so that you can include those caveats. And that may be enough, if you say, but we didn't consider, so for example, right now we're trying to do a, evaluation of health homes in Medicaid. Emily's on the project. It's been a disaster from the get-go. But the intervention keeps shrinking and then changing. And so, I'll be honest, community health workers are a part of the health home. I went into this wanting it to work, right? And wanting to say, hey, Medicaid's investing in this, it's going to be great, the state should expand it. But there's a good chance we're going to see nothing, right, out of this. But then the key piece is, making sure that from our standpoint, from advocates, but also from Medicaid standpoint, whoever, how can we argue that those results may or may not be valid, right? So for example, if it's completely underfunded and you actually can't do what you said you were going to do, then you may have no results. And then it's just not because it doesn't work. So I think just playing through some of those options and talking through what some of the rationale is could help other people.
Yeah, and I think in thinking about measuring some of those things, like you're saying, this brings in like the implementation science part of it. Some of those process type measures of in terms of, if you have a proven intervention that works, the science for a community health worker or this medical home, what are some of the things in the dissemination and uptake in those things that might impact whether or not, that part of it is not necessarily testing the efficacy, it's just this idea of the adoption, so I think as the field of implementation science emerges, incorporating some of those measures, even if not a pure IS study, can help understand if it didn't work, why didn't it work, instead of hand-waving in a discussion about, well, we think this, that, or the other. If you can measure some of those things ahead of time.
Yep, I agree. Okay. All right, so now you've done your background literature search, you've thought through the merits of doing this or not, and you've decided you're going to do it. So now you've got to write down your question or your questions. And you have to think about, some of the pieces that we've been talking through. Is it original? Is this new? You've now done a literature search, so hopefully you know that by now, or you know which facet of it is new. And then phrase your research questions in neutral terms. Again, that's to allow for either outcome, right? Good or bad, or positive or negative, not good or bad.
Or neutral.
Or neutral, or not, or nothing. And then you have to really, now we're back to the not wanting to be under a pile of papers. You need to think about, is your question clear? Is it focused? And is it complex enough to not just be a yes, no, simple Google search, right? Something that's going to be more interesting. So thinking about that, we're just going to look at a couple of examples. Then we're going to go back to our original research question. Oh, and a caveat here is, I think sometimes I remember doing this and thinking like, I can't commit to a question right now. Like, I was sort of overwhelmed with the idea of writing down a research question. So the caveat here is that this doesn't have to be like your only research question ever. It's not like your whole career. It's just simply a research question. It could be for a paper. It could be for a project. And so I want to separate this from the idea of your research interests, right? Like your research topic or your research interest is one thing. And then you might have several research questions within that. And that's where we get into this specificity. Okay. So thinking first about clear versus unclear questions. So here's a question. Why are social networking sites harmful? Let's critique this question.
Unclear.
Unclear. Good. A vote for unclear. Everybody agree? Okay. What is missing? What do we need to do? What makes it unclear?
Like defining harmful.
Go ahead.
Like defining what is harmful.
What is harmful? Define harmful.
Which social?
What social networks? Lots of social networks. Okay, what else?
Establishes bias in a way.
Oh, sure. It sort of assumes that it's harmful. Yeah. The lie piece of that does that, right? What else? Anything else? Yeah.
For what?
For who? For what? Yeah. Okay, great. Those are perfectly correct. So a better question might look like this. How are online users experiencing or addressing privacy issues on social networking sites such as MySpace and Facebook? So all the things that you guys pointed out, they sort of fixed in this, right? Okay. Another example. Focused versus unfocused. What is the effect on the environment from global warming? Focused or unfocused? Okay, why is it unfocused? Other people, new people.
Which environment are you talking about?
What's that?
Which environment particularly?
Yeah. On what part of the environment?
Yes.
What the environment's big, yeah.
What effect?
Okay, great. Yeah, what is the effect? How do we define effect? What does that mean? Anything else? This is pretty good. Okay, so a more effective question could be, how is glacial melting affecting penguins in the Arctic Circle? I did not make these questions up. Isn't that a cute one? I was like, I love that. Okay, I had to change the next one though because I hated it. Okay, appropriately complex versus too simple. How are doctors addressing diabetes in the U.S.? Too simple. Also kind of unfocused. Lots of things are wrong with this question, right? Okay, good. So something that would be a better question. What is the most effective second-line agent available in the U.S. to treat adults with type 2 diabetes after metformin fails to maintain glycemic control? And that's actually the research question of a study that we have here at UAB out of the Department of Health, Nutrition Sciences. So it answers a lot of those questions and helps us focus in on what's missing, right? And allows us to be very targeted when we do our search, when we set up our project, when we think about our methods. Okay. Yes.
So this is since I just recently took this qualitative course, qualitative methods.
Qualitative methods is slightly different.
Yeah, so this would be appropriate, like closer to the question number 1 and more quantitative methods. It would be closer to question number 2, but the mixed method.
True, but I
explains both,
yeah,
right?
Yeah, so mixed methods allows you for a very narrow, although I would have a caveat to that slightly. I think actually when we write the question, the scientific question for a qualitative path, we actually narrow it more than we think we do. When you go in and ask your question to the group, to a focus group or in a semi-structured interview or nominal group take, it's very open-ended, right? But by then you've already selected your sample, you've selected your specific condition, you've narrowed it already. So you go in with a qualitative question. This isn't the research question, the question you're going to ask participants. This is the question you have. So you might say something like, how are social networks harmful? Might be the question you go in and ask a focus group. But by then you've already written among adolescent, first-generation Latinos living in Alabama. You know, you've already specified that, hopefully, or you're going to get, so I guess I would argue that even with a qualitative study, even though the question you ask participants and the way that you go in may be more exploratory and open, you've probably set parameters that have allowed you to make it more focused. Otherwise, you would get an overwhelming amount of data, right? Okay, other thoughts? Okay, now, how much time? We're going to pivot to going back to our original question. So now I want you to go back and look at your original question that you wrote, and you may have totally nailed it and already done all this stuff, but in case you didn't, take a look at it and see if there are ways for you to improve it, or maybe you've been doing that all along the way as we've been talking. And then I'm going to ask for people to share their question.
One thing I sometimes see in early question development, if you use that as an example, somebody might say, how are doctors and nurses addressing diabetes? Just like in English class, I think it's really important for it not to have more than one parameter on each end, because
no double barrel things.
Exactly.
Yes.
They do things differently, so it's more than one question.
Great, great. And that speaks to something that I actually kind of was on one of these slides that I skipped over. And that was, the other thing you have to think about as you think about your research question is this answerable? And that gets at it a little bit. Yeah. What's it going to take to know this? Is it knowable? And do you have the data sources or the means of getting the data that can allow you, because you can ask a great question that nobody can figure out how to get the answer for, and then it's dead in the water. So you have to figure out, do you have the data sources available? And then it's kind of this iterative thing, right? So you might have a data set that's nearly perfect that allows you to ask a related question that isn't exactly your question, but that's okay. Questions can change as you figure out, what you want to know, doctors or nurses or both separately. Or I have data for this but not that. It's been 3 minutes or 4 minutes, right?
I don't know. It's been working out.
1 or 2 more minutes. Oh, everybody maybe it's done. Anybody still working? Okay, great. Well, so we're going to go around the room and share a question, if that's okay, because this is about a safe space. And so I'm going to start right here. So you can, if you feel like you want to, you can start with your first question and then tell us how it evolved, or you can just, if you started out with the most perfect question, you can just give that one.
My initial question was, does socioeconomic status impact pain experience in individuals with chronic low back pain? And then I ended up with the question that states, does race mediate the relationship between socioeconomic status and heat pain thresholds, heat pain threshold responses in individuals with chronic low back pain? So I actually just added them without to specify and then talked a bit about the specific way that I would measure pain experience.
Can everybody hear him? Okay, great. And so I guess, so does anybody have any comments? So it definitely got more specific in terms of the measures, right?
Yes.
Anybody have any comments? Is it okay if we help each other? Is that cool? Okay. Anybody have other questions about his research question? Yeah?
I sometimes struggle with, can you ask yes/no questions, or should you have what is the impact or whatever? So that kind of I don't know which way to go sometimes.
I agree.
Clear binary.
You mean asking what is the effect or does it
Versus
affect?
yes.
Emily, do you have an official answer on that? I would say either. Is my gut.
Could you just say to what extent is there an effect?
What is the association? Because it could be 0, and that answers the does, right? So if the answer is it's big, it's small, it's nothing, and you're open to all of those suggestions, then it could just be what is the association?
So I think I might add too that I've always thought the most interesting research question is that no matter what the answer is, right, it's interesting. So even if it's not binding, you can still publish it because it's an interesting answer. And so I think it can somewhat be binary, but you need to be able to have more involved in that question to be able to answer why the outcome is whatever it is, right, to that extent. So if it's yes or no, that these are the things that are sort of associated with that outcome, that's why it's either one way or the other, to help explain that, right?
Absolutely. Yeah. That would be that's the hope, right?
Yeah.
That you have whatever the
Some
answer
possible-
is, it's helpful.
Yeah.
Can you read your question out loud one more time, the last one?
Does race mediate the relationship between socioeconomic status and heat pain threshold outcomes in individuals with chronic low back pain?
Is there anything anybody else wants to know about that?
Do you know that socioeconomic status is associated with the pain response?
Yes.
Okay. Because that was my first question, because I was like, well, the mediation question is sort of the second stage question. So yeah.
So,
But that's an
Yeah.
issue of not knowing the field.
from the patient clinical perspective, so would you like to narrow down your definition of the chronic back pain? So are those patients, for example, with the pain related from cancer or non-cancer? Just because it's a very broad category.
I had a similar thought. Who's the sample? Is this among young people, old people, everybody? A southern sample? All kinds of back pain, cancer, do you know yet what you want to do? I mean, it's okay if you don't know yet what you want to do, but.
Yeah, so our R1 is actually, we're studying here, it's like a general, we want just general people in the South with chronic low back pain.
In the South? Adults?
Yeah, so in Alabama, adults
Adults in Alabama.
over the age of 18.
Okay, that's getting a lot more specific, right? That's great. Yeah, okay. Awesome. Any other comments? Okay, next. It'll get faster as we go.
My first question was, what are the predictors of unmet need for healthcare in the transition from adolescence to young adulthood? And I realized that predictors, I know what predictors I'm talking about, but it's not really in the question. So instead I revised it to my kind of dichotomy in my dissertation of, do SES factors or health behaviors better predict unmet need for healthcare in the transition from adolescence to young adulthood in a national sample?
Great. Okay, good. Anybody have anything to add or ask?
Maybe some more specific. What is unmet need for healthcare? That's can be a little bit broad. So have, just a little bit more specific about how's that operationalized.
All right, so there's a little variation between the first question I came up with and the second one, but the question is, how does the perception of discrimination influence depressive symptomatology in immigrant children?
That's where you ended up. Okay. How does depressive symptom, say it again? How does perceived discrimination? And do you have some sense of what your sample, where you're pulling from?
As far as the immigrant children, I do. I guess I would focus on a particular group of immigrant children. So should I be specific in defining that?
Yeah, so you would pick, and if you can, and it doesn't necessarily have to be. So you just have to narrow down the parameters, and how you do that doesn't really matter. It could be kids from different places, or it could be, it doesn't matter how you narrow it down, but how are you, because that's like, you have to figure out how you're what are the parameters of that sample going to look like? Where are you going to find those children? Or their outcomes, or their measures, or maybe you're going to collect them, but even then you have to have a group. Like, it's almost like, think about in some ways, your eligibility criteria.
Yeah, and just to piggyback on that a little bit, especially I think when we're talking about children, because of the differences developmentally in different age ranges, I think it would be really important to define what that age range is that you'd be looking at. Great question, though.
Other questions or comments about that particular question? This is not meant to be critical or make you feel like your question isn't good or anything like that. And your question will still maybe change, but this is just an exercise to get us thinking. You want to?
So mine may be very specific. So does adherence to low-salt diet reduce the 30-day readmission rate for the heart failure exacerbations among patients with the preserved ejection fraction?
That's very specific. Which is awesome. Did it start out like that? Today. It probably didn't start like that.
Kind of. What about that?
Evolved today, yeah. Out of curiosity, and not that you would have to put, you obviously can't write your entire method section in your research question, but how do you want to define adherence to a low-salt diet? Because that's tricky, right?
Yeah. So it's probably by some sort of diet instrument. So questionnaire.
And even in a question, it's not even unreasonable to say, as measured by food frequency or whatever it is you're going to do. Just to really make it great. Any comments or questions about her question? Let's just keep moving around the table.
Okay, so my original question was more vague, so it said, how can we best account for missing diet data, especially as applies to outcome of diabetes? And then the final question I came up with was, how do methods for addressing missingness in diet data, such as inverse probability weighting and multiple imputation, as well as other methods, compare as relates to the outcome of diabetes in regards to the set?
Any questions or regards gurus have ways to make that more specific? That's pretty good. Nice evolution of the question. I like that.
Trying to make it more.
Like, use yours as an example. Okay. Go ahead.
Mine's not so developed, but you want both before and after?
Sure.
I guess I started with, what is the ideal palliative care intervention to improve quality of life in patients with ESLD and their caregivers? And then I kind of changed it a little bit too. So what is the impact of a palliative care intervention on symptom burden and quality of life on patients with ESLD or end-stage liver disease?
Comments?
I guess I would just kind of specify what kind of palliative intervention.
Yeah, that's kind of, that was my first question. And I was like, well, I don't know how to,
I mean, you could
define that further. I don't know.
Do you know what the intervention is?
No, and that's kind of
So if
what
you
my
want-
qualitative stuff
Yeah,
is
so
supposed to
you
be.
could back it up. I mean,
Yeah.
you're doing that, but the precursor would almost be, what are the most effective components of a palliative care intervention? To
Reduce
reduce.
the burden and improve quality of life among staff.
Then you'd have to have like some potential components figured out, but
Yeah, right.
to start to compare. But it just starts to push you in that direction of being really specific. And then how would you define, what makes them effective? I guess as measured by the symptom. Okay, great.
Mine started out as kind of a twofold. What are the contributing factors of vaccination hesitancy among an immunocompromised population, and then to what extent would online intervention increase vaccination rates? And so that is kind of two aims. So going to the second aim, to what extent will an online intervention, so a patient-activated learning system, online intervention, increase vaccination rates among an immunocompromised population or a more specific RA population?
Okay. A rheumatoid. Okay, great. Yeah. Adult.
Adult. That's a good distinction. Adult. And then what vaccinations, perhaps a specific vaccination or a specific list of vaccinations, and then is it among an unvaccinated population, or is it among a vaccination hesitant population? So some things to cover.
Yeah, and thinking about how you operationalize that, right? Even if you can't pack it into that question, you're sure going to need to know it.
Absolutely.
Yeah, great.
So mine started complex, just being more of a methods-based person.
You simplified yours.
Well, yeah, so I was kind of like developing it as I was thinking more, but really it was just kind of expanding on some of the work that I've already been doing, looking at hypertension and incident heart failure in regards, and some of the things we've seen is that people we looked at aspects of like how long somebody had hypertension, and so we saw that people with both long and short durations of hypertension had increased risk, and then additionally how people with even controlled hypertension had some increased risk relative to people with no hypertension. So it really got me thinking of more of like the life course kind of burden of blood pressure and how that affects risk. And so my ultimate question ended up being, how does variability in systolic and diastolic blood pressure from adolescence through middle age impact the risk of developing incident heart failure in older adults? And so just thinking about the complexities of it, thinking about finding data with like serial kind of repeated measurements, and very stringent kind of thorough follow-up for those individuals. And then additionally, one of the next steps will be thinking about adapting some of these ideas to EHR data more. Yeah.
Do you think there are databases? So this gets at that feasibility, and you're already sort of thinking about this. Are there databases that would allow you to answer that question? Or have you walked around with blood pressure monitor on?
There are quite a few cohort studies that have like serial kind of follow-up. So cardio is one of them, where they've had like year 0, 2, 5, 7, and then they do like every 10, 15, 20. So there are a lot. That's probably one database I could look at, and it would probably take a little more developing. But yeah, just finding those good repeated serial measurements.
Cool. Matt, I was wondering, are there any databases like that you could get access to from countries that have better primary care than we do, that maybe have had EHR data a little longer also?
Yeah, absolutely. I think some of the countries that have like universal health care probably have very thorough kind of measurements on their on people covered. So yeah, just like the UK and like Swedish cohorts. Yeah.
One thing you might want to think about, people have done studies sort of like that in countries that have universal conscription. And so there's usually some sort of exam at 18.
Okay.
Or, around, late teens. And people have done some stuff in Sweden with the conscription, I think also in Israel.
Cool. Thank you.
So my first one is obesity related to patients' readmission. Then the second one is patients' weight, how patients' weight influence patients' readmission among adults with heart failure. A little bit specific.
Thoughts about that?
I didn't hear the last part, sorry.
So how patients' weight influence patients' readmission, among heart failure patients. So the only trouble with this question is there are actually
patients who will be readmitted, so they will be volume overloaded, so their weight will be higher than was in baseline for them. So this is maybe kind of, I would say, it's not a mediator of this relationship, but the clinical perspective from that will be very complex because it's one of the part of the heart failure exacerbation state that their weight is higher.
Already high.
Yeah.
Do you mean like their core BMI, or are you getting at that idea around their weight being higher?
So you can look on the central adiposity, or you can look on the kind of what's the circumference measure as opposed to the BMI, because BMI will be high by the definition of the clinical state, because they will be volume overloaded at the time.
Okay, thank you. I would also say you may want to consider like obesity and weight. So there's this obesity paradox when it comes to, you said adults, so I don't know what age you're looking at, but given heart failure, it could be older adults, where obesity is actually protective because they're not frail, but inactive is where there's this sort of trade-off between the two. And so you may want to look at different aspects of the same construct of what you're interested in, perhaps.
Stratified by age or something.
Yeah.
Thank you.
And some more specificity in terms of weight measured when. Does weight at the time of discharge,
I agree.
that also addresses your concern. If you're going to measure weight at readmission and folks aren't readmitted, then you can't measure in your kind of control arm or comparator arm. With all the caveats of, is it more than weight?
She said readmission.
I think so, right?
Was readmission?
Yeah.
And readmission within a certain time frame?
30 days.
30 days.
Yeah.
These are all the key things you want to
Probably use just old adults because we have data from claim data from.
So you could say 65 and older.
Yeah,
30-day readmission, 65 and older. See how that starts to really let you, and then when you look at the literature, you know exactly what you're looking for.
Thank you.
And then realistically, it would be, if you were thinking about the age, it would be like 66, because you want to have like thinking about like considerations for your data using claims, you'll have to have like a look back period, make sure they have continuous coverage, all that kind of stuff. So, I've done a little bit of work.
Words of wisdom.
Well, I would say getting to the other point, will claims give you the amount of granularity you need to get these constructs?
Probably just for the outcomes, right? You'd have to pull data from different places, right? Are you thinking about in a hospital system in Birmingham, in an academic health system in the South?
I try to use I2B2 data from the
Okay.
Yeah. So my question is a little more broader qualitative question. So I'd like to explore first and then follow up with more specific quantitative questions. So what are the barriers and facilitators in initiating healthy lifestyle / nutrition discussions among cancer patients by oncologists in oncology clinic in South?
Okay, good. A lot of specificity in there.
Inequalities, yeah.
Yeah, I think the open-ended nature of the question isn't an issue.
Yes.
Questions or thoughts about that? Do we have everything we would need?
So I guess I would just kind of specify, so what kind of nutrition? Are you looking specifically for sort of, that, for example, there's DASH diet, there's Mediterranean diets, what do you think is
any nutrition, because physicians don't have much time to talk, so just initiating with this conversation.
Touching on nutrition at all?
Yes, just touching.
Are you asking pediatricians and adults?
This is adults.
It's all adults.
Yeah.
Any kind of cancer.
Yes, any people coming to the oncology clinic with any cancer, oncologists, are they initiating, are there barriers and facilitators in initiating? Maybe I would specify new coming patients, because I have so many follow-up visits, but.
Could different kinds of cancer influence a physician's likelihood of discussing nutrition?
That could be, but the person I'm interested services. I'm not looking at one cancer type, but I'm looking at more, health services, preventive services, delivery services in the clinic.
And this is among cancer patients, not survivors.
Yes, cancer patients.
Any thoughts?
So
Yeah.
Is this doctors, did you say? Was it physicians?
Oncologists.
Okay,
Not
oncologists.
primary care. Not
Would it be more likely that someone else in the clinic would be having that conversation as opposed to the oncologist?
So yeah, I'm personally interested in oncologists because I have information about primary care. We have so many people involved in that process. Nurses, social workers, nutritionists. There's so many people out there. But I'm curious what's coming out of the oncologists.
Either consider as one of your major predictors or as a stratifying factor, is there some sort of, like, is the cancer itself affecting diet?
That's what I was
Like,
thinking.
is it about having that, or about people who are undergoing
It's a very good question.
very different than someone who's having breast surgery or
Right.
breast cancer. So I think that those are potentially, probably if somebody's having
Head and neck cancer,
there's probably much more attention to nutrition.
And some of these are just MSA, so I think it's not even the time of cancer, but it's which state of the treatment these patients are. For example, the patients are on chemotherapy. So they want actually to talk about the diet that they have now at the time of the clinic visit. So I think it's a little bit where they are in the stage. Like maybe they're far away from their treatment and they're coming in to check in.
Yes, so this is what I just had a conversation about the first visit during when they first visit the hematology oncologist. They have an
Initial assessment.
Initial assessment. Yeah.
Would you want your sample limited to first-time cancer patients?
This is survivors or recurrence, right? We can divide it.
Just one more question. If it's a first-time visit, you would imagine that there's a whole lot of questions that the patients would have about their actual cancer, their survivor, that it might not be the best time for the doctor to talk about that, and it might not be the best time for the patient to receive. It's just a thought. That could be a confounder that
You're already answering the question. I'm very curious to know your. So giving the answers already. Yeah. Yes, that's wonderful. I would be curious to know all of that. This is the point of the whole research. I want to collect as much information as possible. Yes.
Okay.
Thank you.
Go ahead.
So it started out saying inpatients with type 2 diabetes with Alabama Medicaid coverage, are there differences amongst diabetes distress based on urban versus rural living settings, like where they reside? And ended up with, in adults with type 2 diabetes with coverage through Alabama Medicaid, do patient-reported levels of diabetes distress differ whether they live in an urban versus rural area? And still need to have some more specificity on in terms of the defining urban and rural that'll actually be operationally.
Thoughts or questions?
How are you defining diabetes distress?
Just measured with the diabetes distress scale.
17 or max.
17.
All right. We have some question writers over here. Go ahead.
So what patient social risk factors such as poverty and social support are associated with readmission penalties for acute care hospitals under the Hospital Readmission Reduction Program?
Social support and what was the other one? Poverty?
Yeah. So social risk factors such as.
And you can just general readmissions or specific kind of disease and
So under the Hospital Readmissions Reduction Program, there are different conditions that are penalized, but more added each fiscal year, which is why I didn't write them all out. So at the beginning, it's AMI, heart failure, pneumonia, COPD gets added,
than CABG and total hip and knee arthroplasty.
So I guess the question, and you probably already know the answer to this, I'm sure, but since you raised the question, but do we have measures of social support and poverty, or how are you defining those?
So the patient zip code can be matched to like things like deprivation index and other sorts of measures that give you a sense of.
And how about social support?
So there are
I'm asking this because I specifically think we should change something so that we actually do get those, but
yes,
this is an issue, I think.
So again, it's not great because you can't always tie it directly to the patient, but things like the census have number of adults 65 and older that live alone, which is sort of as close of a proxy as I've been able to find of social support. So folks that are 65 and older that live alone, sort of likely, right? Like you don't have a caregiver if you're discharged. So that's one example.
But does that account for like if they have family close by or not? I guess there's not really a way to account for that. Like if they have family or friends that are close by, that would be so.
Yeah, there's lots of, so that's the thing. Like a lot of these things are you're just trying to find the best proxies available.
Yeah.
Maybe the specificity of as measured by census tract data or census block data to distinguish that it's not individual level, but that you're deriving that from these aggregate population data.
Do we reliably capture whether somebody lives alone or not?
Not in claims, you can't.
I'm not sure we do it in the health systems. Do you notice?
No, I mean that's
It's not captured
so what we
in
capture
electronic
is
record
married
amount.
We have married.
Psychotic folks.
Yeah. And not in IDX either, because IDX is a separate administrative system.
Marital status is captured, but it doesn't. I don't know that it captured if you've had a life
It doesn't
partner
count
for
for
50
partners,
years.
yeah, friends, cohabitate, anything of the nature.
Okay.
I think the only regards Medicare linkage may help with that because regards has a questionnaire.
That's a good
Dr.
idea.
Lovehan's on it already.
Okay, good. Great, so you're in good shape. Okay. Coming around to the other side, Emily. Oh, do you want to go?
Well, I haven't started my master's degree.
You're just observing, it's no pressure.
So this is just kind of a thought I had this morning when I was driving here. Are suicide rates associated with the lack of healthcare coverage in Alabama state residents ages 26 to 40? And I know lack of healthcare coverage should probably be defined. I just don't know what data set I would use yet, and I would like to look up the data set first to see what kind of questions they have regarding that.
It's a pretty good question.
You need that notebook.
Hopefully you didn't write you call it on the way over, but
In order to be able to find a data set with a larger sample size, you might want to consider broadening to suicide attempts.
Okay.
You might find more data sets that way.
So I think ER data would be helpful in that.
Yeah. I wonder if there's there's hospital data sets that talk about. I'm wondering, Emily, what's the name of that data set that we used for?
The HCAP data?
Yeah.
The
You think you could use something like that?
I don't remember the.
I can't remember what it stands for.
But it's a sample of admissions. And there's a similar one for emergency departments.
And it has insurance status.
It has
Probably
insurance
has age.
It definitely has age.
And admitting diagnosis.
You need to look because those would go in as they're a separate coding system. Injuries are it's a sort of subset of the coding systems. And they're not always very reliable. But yeah, it would you could use the age code. We have. Well, I mean, so you can look at hospital admissions, and then there's also a similar data set that for people who showed up at the emergency room and were discharged from the emergency room rather than emergency room to hospital.
I bet for suicide attempt, the hospital admitting diagnosis would be more reliable than the ED admitting diagnosis because it feels like at the ED, maybe you don't even know what's going on. They just come in unresponsive, and that's the diagnosis. I don't know. Maybe not.
They would have a discharge, so
So you
wouldn't
go by
want to
discharge
get
maybe from
independent
PD.
diagnosis. You want the
Yeah.
discharge diagnosis
Yeah.
because by then hopefully
They figured it out.
yeah.
But then it's thinking about the specificity of the question, healthcare seeking persons, right? Because there's probably a number of folks who maybe have had suicide attempts that haven't sought healthcare, and just thinking about the implications of confounding about how does having health insurance influence,
And this is probably way more information than you probably need. But in billing systems, often people who are brought to the facility already deceased, they don't show up in the billing system because the Medicare doesn't pay. So if somebody is found unresponsive, brought to the hospital and already dead, then Medicare doesn't pay for that, so they don't show up.
Well, part of the risk of it actually, because sometimes they don't even know the name in the ER of these patients, and they, show up and they already passed. But I would probably also look at we look on the emergency department data is looking on the ingestion. So ingestion, that would be a diagnosis they usually put for the intentional overdose or something.
and this EMS, I know Jim Galbraith has done some neat work looking at opiate, kind of with the buprenorphine, or naltrexone, administration by, so just thinking about other ways to get at the sample and the population,
It's speaking of a personal interest in a hot area, this is a good example.
And you could actually maybe do this in ITV too as well. I mean, that would be one where you really could look at it.
Market administration. Yeah, well done.
All right, last but not least.
I wasn't here in the beginning, so my question did not evolve, but is neighborhood racial diversity associated with perceived experiences of healthcare discrimination and internalized HIV stigma in women living with HIV in the United States?
You benefit by walking in there. Any questions or comments about that question? It's very specific. So that's an awesome one to end on.
How do you measure neighborhood
We have census tract data, and it's calculated kind of a racial diversity index, which is empirically for.
Are you going to use GIS?
That's how it's. Yes. No. Yes.
All right, guys. Well, so we ended up going to 9:25. So that was great. I hope that was helpful. It was definitely fun. Hopefully, we help people speak to the fire on being a